In this video, we present two cases of false passage formation in nasolacrimal duct stenting, highlighting the benefit of nasal endoscopic visualization. The natural external ostium can be seen under the inferior turbinate. The stent can be seen passing under the nasal mucosa but not emerging from the terminal end of the nasolacrimal duct. It is not possible to manipulate the probe to pass through the ostium, and further advancement of the stent would simply tear through the mucosa. This is another demonstration of the metal probe pushing against the nasal mucosa from the inner false root. Finally, another example of the system patency with fluorescein wash. Another proximal probing is shown in this second patient. Nasal endoscopy shows the stent emerging from the medial side of the inferior turbinate instead of under the inferior turbinate where the terminal end of the nasolacrimal duct should be located. This is highly likely to be a false passage unless this patient has extremely aberrant anatomy. As the second half of the stent is inserted through the upper punctum, it finds its way to the same false root external opening anterior to the inferior concha. Formation of a false passage has several issues. Firstly, it causes unnecessary tissue trauma. Secondly, it will only achieve the aim of overcoming an obstruction or dilating a system if there is a portion of the stent in the correct location prior to it starting the false passage, and the obstruction or stenotic region is in this section. Thirdly, the stent is likely to be much more difficult to remove, as it will be held firm by the surrounding tissues and may snap on removal. One should be familiar with the anatomy and direction of the system while performing stenting. Upon entering the punctum, the stent should pass through the vertical canaliculus, which measures 2 millimeters in length and extends perpendicular to the eyelid margin, before widening to form an ampulla. At the ampulla, the canaliculus makes a 90-degree turn medially. The canaliculus continues horizontally for 8 millimeters following the arc of the eyelid. About 90% of the time, the upper and lower canaliculi join proximal to the lacrimal sac to form a single canaliculus of 3 to 5 millimeters. In 10% of people, the canaliculi enter the lacrimal sac directly. Rosen-Muller's valve separates the common canaliculus from the lacrimal sac by tissue infoldings. As soon as we have entered the sac, we should plan our descent. The lacrimal duct then extends infero-posteriorly from the sac at an angle ranging from 15 to 30 degrees. In the mid-sagittal plane, it extends inferolaterally at an angle of about 5 degrees. The duct measures approximately 12 millimeters in length and 3 to 5 millimeters in width. At the valve of Hassner, it opens into the inferior meatus. Syringing the nasolacrimal system with a viscoelastic substance can aid stent insertion and reduce the risk of catching on the sac or duct walls, which might then form a false passage. Placing a stent under vision using an endoscope allows for early detection of this complication if it occurs, and hopefully modification of the direction of the passage to stay within the lacrimal drainage system, avoiding any further trauma, and ultimately conducting a procedure that will have the chance of a successful outcome.